All right, welcome everyone to our On the Pulse series. Today we will be hearing from Dr. Marc Newell regarding cardiovascular telemedicine care in the age of coronavirus. But before I have the opportunity to introduce Dr. Newell, I wanted to tell you a little bit about the Minneapolis Heart Institute Foundation. Many of you might be familiar, so tell your friends all about us, but those of you who are new, it's important to understand that we are an independent, nonprofit research and education organization. And we have been doing research and education in cardiovascular health for the last 38 years. And this is only possible through our partnership with the Minneapolis Heart Institute, which is located at the Abbott Northwestern Hospital, which is the flagship hospital of the Allina system. So you can see in the graphic to the right that our mission and vision is all around cardiovascular research and education and how that improves the care and quality of life of individuals. Well, pictures are always the best way to describe what we do. So you'll see some of our researchers. And we are able to do first in human and phenomenal clinical trials here at the Minneapolis Heart Institute Foundation with over 200 active studies. 100 of those are really in industry-sponsored clinical trials, and the other 100 are led by our physician-initiated research. And these studies touch the lives of over 2,000 patients. We also are committed to the next generation of healthcare providers, and a program we're very proud of is our MHIF internship program, where we have almost 200 alum who came here on their way to medical school to do research side by side with one of our physicians and our research staff. Many of them get to publish, go to professional conferences, and the majority are now practicing medicine. In addition to that, we provide CME for our healthcare practitioners, and our physicians are committed to publishing in peer-reviewed manuscripts, making sure that our research findings don't only benefit the patients here, but patients around the globe. We love to look at our partners, our staff members, our physicians, our patients, and our community partners and our board members. And these pictures demonstrate that spectrum of partners out there. As I mentioned, we've been able to do first in the world, first in human trials. We have helped patients live healthy, full lives, and we celebrate with them, and we appreciate that they are advocates for our research and education. We do our best to get out into the community and raise awareness. And again, we are pleased that much of our research becomes national and global protocol. Our work is made possible by people like you. With the philanthropic support of the community, we are able to continue the tradition of 38 years of research and education that improve cardiovascular outcomes. So we are grateful. Thank you. Lately, we have been in the news. We are all hearing much more about COVID-19. We'll hear more about that from Dr. Newell, but this is a research opportunity for us to understand how COVID-19 does impact heart health. Around that, you could also visit our website, where we have interviewed many of our physicians on their perspective during this time. So please take a moment to visit our website. With that said, it's my pleasure to introduce Marc Newell. I'm very grateful that he's a board member of the Minneapolis Heart Institute Foundation. He is also a senior consulting cardiologist and vice president of operations at MHI. And he has many research interests. Some of them include cardiac imaging, acute heart attack care, and atrial fibrillation detection and therapeutic hypothermia, among other areas. Most importantly, Marc loves his patients, he loves providing the best care, and he loves ensuring that MHI has the infrastructure to not only provide the care, but the future care that we can provide through research and education. With that said, I'd like to invite Dr. Newell forward for our next On the Pulse presentation.
Thanks, Chris. Good afternoon. Thank you, Chris. That was quite the introduction. I hope everybody's doing well. Hope everybody's staying safe and staying healthy and enjoying a little bit of sunshine. It's kind of nice to hit springtime and think about something other than the pandemic for a little while. So today I'll be talking about cardiovascular telehealth and telemedicine. and putting it in the context of where we were before the pandemic, what we're doing now during the pandemic, and actually some of the learnings that we can take from our prior experience and what we're experiencing now to how we can actually do better as we go forward in the future. So I'll talk about our telehealth program, which has actually been now going for over 5 years. It started in June of 2014, and talk a little bit about why did we do it, what were some keys to success for our program, describe the program in a little bit more detail, and then talk about programmatic growth, and then how this all applies now that we're in the middle of the biggest pandemic of our lifetime. Found this very interesting. This was a quote in 2017 in February, talking about the American Heart Association saying, we really need to invest in telehealth. Telehealth is the future of cardiology. It's critically important, were their words that they used, both to reduce burden of disease, but also to reduce costs as we go forward, which of course are big focuses for all practices. My favorite part of this whole article is that they emphasized over and over again how critically important this was, and they had how many real-world examples to show? 0. So they were talking about how important this is, but nobody had really done it yet or published on it yet. As Chris alluded to here at Minneapolis Heart Institute, Minneapolis Heart Institute Foundation, we're very keen on not only trying something new, doing something that's better for our patients, but then also getting the word out. And so we're very proud of this publication that was published just 8 months after they were saying how critically important this is to do telehealth in the real world, about our real-world experience of our telehealth program. So this is published in the Circulation Journal in October of 2017, describing our program, which I'll go over with you now. So what we really found is that, like anything, telehealth is not at all about the technology, it's really about the relationships. As you saw in that first slide, we have over 38 partners in regional medical centers, clinics, small towns, rural sites that we've partnered with now for over 30 years. Having those relationships, having those established partnerships made it very easy for us to say, how can we serve you better? And that really led to the fact that we were not getting good patient access, or as good as we'd hoped to do. We also developed with our long-term vision and strategy for the practice and for our outreach program. And then, of course, wanted to make sure that it was right by all the important parties. Most importantly, the patients. And for patients, the benefit of telehealth is they get more access to specialty care. They actually get it closer to home. They don't have to drive to the big city or make that choice of, do I have to drive to the big city or do I have to have my kid take their day off of work to come take me to the big city? And one of the focus that we hear all the time nationally is, the right patient at the right time in the right place, and telehealth really checks all those boxes from a patient-centric standpoint. For our partner sites in the rural communities, there are a lot of wins there as well. They obviously get more care, but not just more care, more access to specialists. If you go, the smaller the rural community you go to, the harder it is for them to get specialty care and to get frequent specialty care. And as you know, in cardiology, there are true urgent situations and, of course, emergent situations. The emergent situations are taken care of through the ER and such, but there are urgent situations. And right now, if you live in a rural community, it's actually the patient that's making the decision of, does this meet the threshold where I really need to go somewhere bigger or not, or do I really need to go to the ER or not? So one of the benefits I've found with this program is we take a little bit of that decision-making process out of the patient's hands by giving them more access in that rural community to cardiologists to say, yep, you need to come for this one, or nope, you're okay, and here are the steps you need to take to be healthier. For specialists, for my partners and our team, obviously there's a benefit to being able to be more present in more places. There's also a benefit to not staring at a windshield for a few hours a day or more. And so having less travel, but still being able to provide high quality care in all these locations is a huge benefit for our partners. And actually the more access to sites, the more appropriate procedures we're doing. And the easier we have to follow up procedures. We see a lot of patients that before the program were a little leery of driving 2 hours to come get a big procedure and then get discharged and be home and be worried about, is there going to be a problem with my procedure? What happens if there is? Do they know how to take care of that? Having follow-ups done via telehealth in short order after a big procedure is very reassuring for patients and for the doctors in the rural community to say, yes, I'll get in, I'll get seen, and if there's an issue, we'll address it and know exactly what we should be doing. There's something that you'll see listed if you talk to any administrators in the country, or if you look at national things about this triple aim. Triple aim is really the right focus, which is how do we lower costs, but yet still provide better care and overall improve health. That should be three very noble goals to shoot for. And when you look through all of medicine, it's really hard to check all three of those boxes. Usually you can get a couple. You can say, well, we're going to do something better, but it's going to cost more. Or, well, if we're going to cut costs, we're not sure that the quality is actually going to go up. When you look at telehealth, actually it checks all three of those boxes. You can get a better patient experience like we just described. Patients can get care close to home, less travel time, less decision making on the patient standpoint of is this worth going in for or not, because they can just go find out. Also improving the health of populations, the more specialty providers in the more appropriate spots. You would assume that that would provide better care. Actually less need for overall specialty providers. We're using our specialty providers more efficiently, using them better. And again, more care for specialists in more locations. Decreasing the cost of care, when you think of buzzwords for telehealth and like to try to keep things simple, access is a clear one that we hear talked about all the time with telehealth, meaning patients can get seen sooner, we can get better access for patient care. The one I've found in this program over 5 years is actually more triage. You know, we assume that we're really good at triaging patients, but as I mentioned already, and a lot of times the patients are triaging themselves to say, does this meet the threshold where I should go in? And I get asked all the time in clinic, well, tell me when I should go to the ER. Well, it's really hard to make a blanket statement of, well, if it's really bad or really, really bad, or if it's this or if it's that. It's really hard to say unless you know the specific situation, yes, this is an urgent thing. This is one's okay, we can treat this, or this one, you're just fine. And so to be able to use that power of just having the expertise from the physician to decide, triage, yes, you can handle this locally with X, Y, and Z, or no, you should come down for a procedure, it's not emergent, or you know what, we'll get an ambulance for you now and we'll send you on your way, is a really powerful part of this tool. And if you can do that better, if you can keep patients close to home, well taken care of at home without having to do transfers that aren't necessary, without having to do procedures that aren't necessary, and less ER visits, that's certainly decreasing cost of care for not only that patient, but especially for the system. When you look at the map of our program currently in 2020, obviously this is the bottom 2/3 here of Minnesota. All the blue dots here are sites that we go to for cardiology and have, in many cases, for decades. If you can see the little green flags there, those are the sites that we do our telehealth programs at. And you'll see they go as far north and west as Fargo, which is our advanced heart failure team doing specialty consults and heart failure to Fargo. And as far south as Blue Earth and Fairmont. Although if you go really far south and east, then you'll hit Naples, Florida, where we started a program now more than 3 years ago. When you look at, just to explain a few of the other buttons, obviously we're zoomed in on the metro. The red sites are sites where we actually have physicians present 5 days a week. So those are what we consider our hubs, where we do a lot of imaging, a lot of subspecialty care on site. So that's the map of our program. Our program actually started with 4 telehealth sites, and if you count them, there's 16 now. One thing that's really helped with the growth of our program, and I think makes a lot of sense when you think about telehealth from a cardiology standpoint, is to engage even our subspecialty cardiology providers. So these are a lot of our proceduralists, people that are very specialized in what they do. They spend their whole day doing vascular surgery, or their whole day doing electrophysiology or heart rhythm issues, or they deal with the sickest of the sick heart failure patients and do transplant and left ventricular assist device, very complex things. So this list of 5 subspecialists are groups that have actually been involved with our telehealth program. And as you start to experience a program like this, you realize that this actually fits them as well as anybody. So let's take an example. We have partners that live and work in the Brainerd-Baxter area, which is a little over 2 hours from Minneapolis. They have, of course, people with all these issues, people that have arrhythmia issues that maybe need a complex procedure called an ablation. And if you're a patient up in Brainerd-Baxter, your previous choices were, well, my doctor said I should probably go get this talked about by one of these EP guys. I don't even know what that is. Should I drive for 2.5 hours to go get the consult to see if I should do this procedure or not? And then drive home and then decide whether I want to drive back for the procedure or not, and then drive back for my follow-up? Now they can actually do that consult via telehealth right at home in Brainerd. So they would just go into the clinic that they're used to going to. They would see a medical assistant or a nurse that would help facilitate the visit with the electrophysiologist that would be the person doing their procedure. So now, as opposed to having to make that decision, do I drive or not? Is it worth it or not? It's clearly worth it to at least have the conversation, and the conversation can be held right at home. And if they're not a good candidate, or if they don't want to do it, which is of course their choice, they absolutely don't have to come down at all. If they find out that they're good candidates for this procedure, they've already met the person that's going to do their procedure. They already understand, risks and benefits and potential complications and what the follow-up care will look like. And they can make a very good decision of, yes, this is absolutely worth it, and schedule the procedure and come on down. So this is something, as I've talked nationally about this topic and talked with other people across the country, that they really have a hard time convincing their subspecialists to say, how is this worth it? Why would we do this? Well, as that example hopefully shows, this is a great way to use this type of service, and it's very rewarding for our physicians because their time is being well used. They're doing these consults for people that are probably very good candidates for these procedures, and so their yield, if you will, from doing these types of visits is very high for the procedures that they love to do and that they're experts at. And so this really makes a lot of sense for the patient and certainly for our program and for our providers. So some of the advantages when I tried to sell this and did sell this to my subspecialty partners is clearly less travel, more access to appropriate patients, a higher procedural yield like I mentioned, and actually they get to know the referring doctors even better. Those relationships are super important, not only with patients, but of course with the doctors that we work with all the time. And just even being able to have them understand and feel very comfortable calling with very simple questions or complex procedural questions. You're really developing those relationships. Like I said, it's all about the relationships and not necessarily the technology. I think, as I mentioned earlier, if somebody has a complication, has an issue, being able to be seen via telehealth that week is very reassuring to know that, okay, nope, that's normal, this is okay, just do this and you'll be fine. Or you know what, that doesn't sound right, we need to take a closer look and let's see you sooner. So when I started looking at patient selection, who are we targeting or who are we trying to help out the most with this program? We really wanted to see those new patients or those patients that needed to be seen as soon as possible. This was again getting at that access and triage buzzwords, which is if somebody has a new symptom, somebody's getting worse, they're not feeling well, we want to get those people in the door to help get them evaluated quickly and get them to where they need to be, whether that's just with medications at home or whether that's for a procedure or for a transfer in the hospital locally or down here at Abbott. So we're really focusing on those type of patients, but as we've found, there's so many things in cardiology now that really require close clinical follow-up. So if somebody gets admitted to the hospital with an acute coronary syndrome like a heart attack, the American College of Cardiology requires that we see that patient within 5 days after they're discharged. I don't know how many of you have looked for a cardiology appointment lately, and ours are out about 2 weeks, and that's better than most places across the Twin Cities and other places. Trying to get somebody in 5 days is tricky when you have a wait time that's almost 2 weeks. So being able to do these visits via telehealth, actually even sometimes facilitating these visits with an advanced practice provider like a PA or a nurse practitioner. Half the battle on these follow-up visits are understanding what happened, why it happened, what the next steps are, why you're taking the medications. And if we can do all those things in the appropriate time frame, which is 3 to 5 days, those patients are 20-30% less likely to come back to the hospital with an issue and be readmitted. And so there's huge benefit to seeing people that have had a recent heart attack. The second comment there is around patients that have had recent stenting or patients that have been admitted to the hospital for heart failure. Again, it's a very similar visit, which is here's why you were there, here's the steps you need to take, here's why you're taking your medications. Very, very helpful, great patient education, great tool to keep patients out of the hospital and from having them come back in. So again, telehealth really is a patient access tool, it's a patient education tool as well, and a great way to get people seen and keep them from having to come back into the hospital. So really this was triggered by a few cases, and again, our relationships that we had with our outreach partners, but New Ulm is a site that's a little over 2 hours, about 2 hours from the Twin Cities here, southwest. They're in a line-up facility, and they have a CEO who's wonderful and a go-getter and wants to be a champion for rural health. So we've worked closely with him and his team, and this is one of our main sites that started the program back in 2014. We started looking at their wait times for a clinic appointment, and they were essentially 6 weeks. This was a clinic that I went to for outreach, and I'll never forget the case of a patient who had been waiting 6 weeks for his appointment to see me and had been having chest pain for 8 weeks, so 2 weeks prior to the visit, or prior to setting up the appointment, and had a stress test that was horribly abnormal. Well, he was told he had an abnormal stress test, he knew he was having chest pain, but again, we left the decision in his hands to say, well, does this meet the criteria where I should just go drive up there and have them do the angiogram now? Or do I drive somewhere into the cities to get an appointment sooner? Or do I just wait? Because I've already got my appointment for the cardiologist, maybe I'll just wait. And so I see this stress test and talk to him about his chest pain, which has continued to accelerate over the 6 weeks, and thank goodness nothing happened to him. But those type of stories are the stories that really tell us, I think, the story of telehealth is the right way to go. Now the wait time for him would have been less than a week, or is less than a week. And so if that exact same situation happened now, he would be seen that week. He would be able to go over his results on a stress test. He'd likely be in an angiogram the same week. And those bad outcomes that could have happened to him can be avoided with a program like this. Blue Earth was the site that we looked at that had the longest wait time, almost out to 8 weeks. And so now with telehealth, our access time is less than a week in all these sites. So we're over 5 years into the program, as I mentioned, and so it's a good time to look back and reflect on growth and what's worked well and what hasn't worked so well. As I mentioned, we're really focusing on those patients that were new or that really needed us urgently. We found that the percent of new patients is almost half, so 48% of our patients are new patients with this program. If you look at a traditional outreach site, we're about 1 in 5 is new, so we're seeing clearly more new patients, more of those ASAP patients that really need to be seen sooner. Interestingly, either by word of mouth or by lack of good care from different systems, we've had other health systems reach out to us to actually join MHI just because of this program, which is not something that we really intended or not something I thought about when I started this program. But cities like Fairmont, Minnesota, Pine City, Minnesota, now Fargo, North Dakota, which has 2 larger health systems, but they do not have transplant or advanced heart failure options. And then again with Naples, Florida, where a lot of our patients travel to that region in the winter, these are 4 sites that MHI was not a part of before, but because of the telehealth program, we're either asked to come in and help provide service, or working again with other systems like in Fargo to provide additional care that they can't provide. So this has not only grown as a program, it's actually attracted new business, if you will, for MHI. When you look at the programmatic growth here, it's been a steady increase in growth, up to almost 1,000 patients seen last year. So again, this is all pre-pandemic. We're up to 16 sites and a large growth over the course of the first 4 years of the program. I think of all the things reflecting back on the program that I was most worried about when we started was actually the patient experience. This is obviously a whole different type of visit. You do have a patient or a person in the room with you who's usually a nurse or a medical assistant that's checking your vitals, checking your medications. So you've got somebody right there with you. So there's that interpersonal part. But the physician or the provider is across the screen. And so would that be something that's acceptable to patients, especially in the demographics in cardiology, which are a lot of people in their 70s, 80s, and even beyond? Well, it turns out we did surveys of our first 500 patients to see how comfortable were they before and how comfortable were they after the visit to see what can we do better. Actually, the pre and post surveys, we saw an uptick. They were probably in the 80th percentile in the pre-surveys, and as you can see, up in the upper 90% in terms of whether they felt it was just as good as a regular visit, whether they felt comfortable with the privacy of the visit, and whether they felt at ease and felt like this was a worthwhile visit that they'd recommend to friends or others. And so maybe there's a percentage of this that's Minnesota nice, but I think what we're seeing reflected probably in these numbers are, again, the access, the fact that they didn't have to travel somewhere that they didn't know, the fact that they got in soon, and the fact that they didn't have to burden their family to go to these visits, probably are all reflected in the satisfaction. And actually our nurse practitioner, Deb Lindgren-Clendenin, who's been a huge part of this program, is actually presenting this this month actually at the American Telemedicine Association in terms of patient satisfaction. So I put this slide in because this is a slide I presented last year at a national meeting about where this could potentially go in the future. And of course, with the pandemic, everything changes, right? And so what we were dreaming up last year was, can we actually do a program where we're seeing ASAP patients from any site that particular day? Meaning if there's 6 different sites that all had an urgent patient, can I as a physician see all 6 of those patients from different sites? Is there a way to make that happen? Is there a way to see somebody that's actually in the hospital or in the ER and truly do the very acute phase of care to say, we do a lot of this over the phone, we do a lot of these, care conferences and such, but is there a way to actually physically see the patient so they know that I saw the cardiologist while I was in the ER and they reviewed everything and they think if I do this, this, and this, I'll be okay. Or they said I really need to come down and then they understand the urgency of it. So we talked about all these. We talked about ways to support nurse practitioners and PAs and maybe in smaller rural sites that don't have physicians or cardiologists present. We also talked about ways to use technology, wearable devices, bedside ultrasound, ways to actually help facilitate an exam when the physician is remote to the patient. Is there a way to do these better so the more objective data we have that we can truly evaluate, the better we'll have an assessment for that patient. This is pre-pandemic, and then of course this happened. So I don't think anybody was fully prepared for the breadth and the scope of this pandemic. But in a way, our program that we've had before really made us nimble for dealing with the pandemic, still taking care of our patients, and then again, hopefully looking at ways to learn how we can do better as we go forward. So understanding telehealth, how we use it, some of the outcomes and benefits of a program like what we've had really allowed us to go to very rapidly to virtual visits during the pandemic. So the reasons to do virtual visits are patients still need care, obviously. Physicians need to decrease their exposure, and same for the staff, the nurses, the medical assistants, everybody in the clinic. When you think about going into a clinic for a routine visit, you're coming in direct contact probably with at least 5 people and maybe more. And so if we can decrease the exposure for the patient, for everybody that works in that office, and for the physicians who may be needed in the ER, or maybe needed in the hospital, as others get sick, there really was a strong need for virtual visits. We found as we've looked at this closely, we're able to transition all of our visits without canceling any visits to virtual visits, starting first with virtual phone visits, where we basically call, review medications, review symptoms, review any home blood pressure or wearable device readings, and then have a phone conversation, physician to patient, about what's going on, what are the next steps. And we had some benefit of people having had recent procedures at least the initiation of the pandemic. One group of people, of course, that we're very worried about were those people that didn't have emergent issues but had more urgent issues. And as you know, we were asked to really eliminate any elective or at least initially even urgent procedures. So you've got patients that have an issue that we know needs to be taken care of, but we're told to put the brakes on and hold and see how those patients do. Well, being able to do virtual visits with those patients regularly, every week, checking in, again, getting to that triage concept of, okay, this patient seems to be doing okay on their medications, they can hold off, they can wait another 2 months until this is recovered. That's great, they're doing well. This patient seems to be getting worse, they're having more and more troubles. This person is somebody that actually really has turned more into an urgent, emergent type procedure. We know that this person needs to have this procedure done, understanding the risks of COVID and infection if they come into the hospital. So this has really been a great triage tool during the pandemic as well, not only to say, does this person need to come in or not, but also just to stay in contact with patients to say, yes, we understand that this is going on, how are you feeling? Yes, we do think you need to come in, or no, I think you're doing okay at home. So it's been a great way, again, to help care for patients. We very recently added a video component to these home visits, so the patient's at home, the physician can be at home or at least be in a sequestered location by themselves, and actually see face-to-face and have a HIPAA-compliant, a privacy-compliant interaction. This is something that we do think can transition post-pandemic. There are certain patients, as you might imagine, that could do very well with these type of visits, people that have stable coronary disease, stable arrhythmias, stable problems. They're just coming in for their routine check. They want to go over their recent ultrasound that they had or their cholesterol profile, whatever it may be. A lot of those visits can actually save the patient a lot and save the physician a lot by doing those from home or doing those from home every other year. So there will be learnings that we can carry forward. The way we kind of viewed this within MHI was that there probably were going to be 3 phases to this pandemic. There's sort of the pre-surge, the pre-viral surge, which we saw extend for about 2 months. And then sort of the viral surge, which we're maybe at the early part of that right now. And then we really think that there's going to be a post-viral CV surge, if you will. So all these people that have had cardiovascular issues, many of them were clearly afraid to come to the hospital to address those issues. We're seeing people put off procedures that were maybe not necessarily elective, but more urgent. And so after the virus is truly gone or under control, we'll have this huge need, even more than before, for cardiovascular patients to be seen, to get their procedures, to be well cared for. And so that's kind of how we've thought through this process. One of the ways that we've helped hopefully unload that back end, that last cardiovascular surge phase, is to actually move a lot of those routine follow-up patients that were due to be seen July, August, September forward into this pre-COVID phase to say, you know what, we can see Mrs. Jones and her stable coronary disease right now in May via virtual visit, and so she won't need that slot in September when somebody who has been putting off their procedure really does need to be seen or really does need that procedure. So we've tried to be thoughtful about approaching the pandemic in a way where let's use our resources, using virtual visits, using telehealth, using these options can really help us be not only giving better care now, but be more nimble later. So if we look at what's now are labeled as time-sensitive procedures, these are procedures that, again, were more in that urgent category where they should be done within the next month or two. Initially, when the pandemic hit, it was let's hold these off because we can do these in 2 months. Well, we're now already over 2 months out from the start of the pandemic. So if anything, there's more COVID now than there was 2 months ago. And so some of these time-sensitive procedures we need to be able to track very closely. And again, a lot of those were done with these visits, these virtual visits. And so once we were given the go-ahead to start moving forward with these time-sensitive procedures, our capacity in our cath lab and our EP labs went from about 40% during the initial phase to right up to 100% within a couple days. And so being able to understand who really needs these procedures, who needs them quickly, and being able to have those conversations and those visits with patients really allowed us to be nimble and provide the best care for patients. One other thing that I mentioned as my future hope for this type of program was could we do inpatient visits to places that either don't have a cardiologist on site or that we can do it again for more urgent patients in hospitals, other places that don't have cardiology. We've not only done that at other sites now, we've actually done that here at Abbott. And so if we have a patient that has known COVID or is a PUI, a patient under investigation for COVID, meaning they have symptoms, highly suspicious, they're usually waiting for the test result to come back. If those patients are very high risk and very highly infective, we can actually facilitate a telehealth type visit with those patients even when they're in our own hospital. Meaning we can review the chart, we can look at their rhythm strips, we can look at their telemetry, we can look at their ultrasound, and we can call into the patient room and have the same conversation we'd have if we were sitting 6 feet away from them in the room. And really the only thing we need to decide is, are there any exam components that we need above and beyond that? And if so, we can get gowned up and masked and go in and do that. If not, if one of our internal medicine hospitalist colleagues has already done that, or we've already had an ultrasound that's going to do better than our exam would anyway, maybe we can just do it just that way. And so we've instituted those type of virtual inpatient visits, both here at Abbott, but translated those type of visits also to other sites like Cambridge Medical Center, for example. So Cambridge doesn't have a cardiologist on site every day, but now they do. Now every day at noon, there's an open slot for an inpatient that needs to be seen by a cardiologist, and we can do the visit that exact same way. We can look at their record, we can review all their objective data, call into the patient room, have the conversation about how they're feeling and what the next steps would be, and actually truly advance their care with being 70 miles away. And so it's been a way, something we're looking towards in the future. The future's here, and the pandemic is a way to really institute a visit like that, which has been really well received by patients and by our partners at some of those clinics. So I think we can even do that more as we go forward. So post-pandemic, what does the world look like? I think hopefully our program, even before the pandemic, proved that telehealth is here to stay, and there's a lot of wins from doing a telehealth type program. Again, hitting the highlights of getting patients in sooner to specialists, especially in rural locations, and really taking the triage out of the patient's hand and putting that where it should be with the physician or the provider. I didn't talk about the financial viability. Clearly the program has grown. We have studied kind of how these patients do from a programmatic standpoint. It's a very financially viable program. So this is something we'll talk about more in the next few years across the country to get other programs across the country to do programs like this. What have we learned from the pandemic? What can we do going forward? As I mentioned, I think we can start to do more and more of these virtual visits at other hospitals that either don't have cardiology at all or have cardiologists a few days a week. This will be a way to really facilitate care, have patients feel like they're seeing the providers because they are, and they're advancing care even without having to be physically present. That's a perfect situation for patients and for providers. And I think, as I mentioned, potentially some of the routine follow-ups can even be done for patients from their own home. Less in-person cardiology appointments, more in-person cardiology appointments for those that have new problems or new issues. I think this will only expand as we look at what's out there right now and what'll be there in 5 years from now in terms of wearable technology. We already have patches that are as small as a Band-Aid that can actually record data on people's heart rates for days at a time. We've got ultrasound probes that are starting to use artificial intelligence to actually have a person that has no knowledge of how to do ultrasound take diagnostic quality pictures of the heart pump and things like that. So I think this will really continue to expand as we move forward. So as a summary, and I look forward to any questions that people have. Telehealth is a key initiative in specialty care for the future. I agree with the American Heart Association that this is going to be key for cardiology as we move forward. It can really help providers triage patients appropriately and, again, gain access for those rural sites to specialists and get people seen sooner. It's a feasible program in terms of growth, and it's financially viable. Again, this pandemic is a whole new world for all of us, and so I think telemedicine's here to stay, and let's be a part of the solution and making it better for everyone as we go forward. So thank you for your attention, and I'm happy to take any questions, and I should say hi to my mom. Hi, Mom.
All right. Well, thank you, Dr. Newell, for presenting. That was excellent. We appreciate you sharing your time and expertise. And as Dr. Newell said, attendees, at this point, we're going to open it up for Q&A. And on your screen, you should see a Zoom Q&A walkthrough. Please follow these directions to submit a question or comment. Just as a reminder, to access the Q&A pod, you scroll your cursor down to the bottom of the screen, access the control bar, and click on the Q&A icon. And Dr. Newell, if you're ready, we have quite a few questions already in the pod. The first of which is, what are the most common conditions that you work with via telehealth, and which conditions does it work best for?
Yeah, it's a great question. We actually will look at any condition, any cardiac issue, we're happy to help address over telehealth. And again, that's part of the triage tool is everything in medicine, the knowledge is expanding so much, and even in cardiology, you know, we have general cardiologists and we have the subspecialists that I mentioned that get really specific in terms of what they do every day. So we're happy to see anybody with any heart-related problem over telehealth. That's the beauty of the program is we can really see anyone. It fits really well for certain people, you know, like I mentioned, people that have new symptoms, new problems that really need to be seen sooner, which, you know, if anybody's having shortness of breath, chest pain, the symptoms that could represent a new coronary problem or a valve problem, those people should be seen sooner. It's also very helpful for follow-up, like I mentioned, people that have had a recent hospitalization, whether they're in the hospital for a heart attack, a stent, heart failure issues, seeing those people, or surgery, seeing those people very closely after their visit, especially if they live a few hours away. It feels so good to get home, it's hard to drive back to say, I want to come do this clinic visit. So really, we're happy to see all comers. It fits really well for people that need or have had a recent procedure or been in the hospital.
Excellent, thank you very much.
Yeah.
The next question we have is, we hear a lot about security issues with Zoom calls or internet chat in general. So how can we feel that telemedicine visits will be private?
Yep. Yeah, it's a great question. There's this HIPAA that people may have heard of, which is a national program to make sure that there's privacy for medical records. And a lot of the software that we use for our program previously and also now is compliant with HIPAA, meaning it's got an extra layer of privacy protection so nobody else can break into the video or break into that stream and interact. I know that's been an issue for some of the services like Zoom and others where they get 600 people on a call and other people can kind of get into those links. This doesn't happen with the type of programs that we use. And we're a little slower transitioning from those phone virtual visits to the video visits for that reason. We wanted to make sure that this was a program that not only worked right now during the pandemic, but was a learning that we could use as we go forward. So it had to be HIPAA compliant and have that extra privacy protection.
Excellent, thank you very much. And yeah, that makes a lot of sense these days especially.
Yeah.
So the process of telemedicine. So for example, if a patient was in Brainerd, do they still have to go into their local doctor's office to access the telemedicine, or can they be at home, or is it a combo?
Yeah, it's a great question. So prior to the pandemic, they would come into the clinic, and so they would come into the clinic that they know and usually go to and actually be treated just like a regular clinic visit. So they'd come in, again, get checked in, go into the room with the medical assistant or the nurse, go over medications, go over symptoms, you know, go over what's been going on, and then they have the technology connected and have that interaction with the physician. We've tried to make this rewarding, hopefully, for the nurses and medical assistants that we work with, because they'll be the ones that'll call us. We're usually, as the cardiologists, reading imaging or doing something, productive with our time otherwise, knowing what the schedule looks like. And when we get called to do one of these visits, we'll have that conversation with the provider in the room with the patient to kind of go over, hopefully give them some teaching and learning as well, and then connect up with the patient and do that visit. The visits end very similarly, which is the physician hopefully is summarizing the visit and going over next steps. The person in the room with the patient will help facilitate whether that's getting a study done or getting a medication. They'll help order those and get those done. So that's the way it was done before. During the pandemic, the reason we started with phone virtual visits was we wanted the patients home. We didn't want them coming in and getting exposed to people at the clinic or the hospital. We didn't want all those people that were in the clinic or the hospital exposed as well. And so that's part of how we're facilitating doing this from home. The trick has always been, at least in my partner's mind, is how do we get a good exam? How do we can I evaluate a person who is remote to me? How can I tell what their heart sounds like? How can I tell, how they really look? There's something that physicians have always described from the very beginning of medical school training, which is the eyeball test, which means if you can actually see somebody, you can tell right away, do they look really uncomfortable? Do they look okay? Do they look pale? Do they look good? And oftentimes when you read through a medical record, you've got this picture in your mind of what they're going to look like. And it's usually wrong one way or the other. You can walk into the room and say, oh, this person looks worse, or this person looks a lot better. And so actually just the ability to see somebody over video is a big difference. But what we've done in the past was we initially started actually with nurse practitioners at the rural sites to actually facilitate a good exam. That kind of got our program up and running. As we got more comfortable with electronic stethoscopes, with other ways to actually facilitate the exam, we've been able to use medical assistants and nurses at the local site, which is more rewarding for them, it's cheaper for the whole system and the program, and it's a better way to facilitate that. So previously, yes, it was in the clinic. Towards the future, again, with all the wearable technology and things that we're seeing, the ideal situation would be the patient's at home or traveling or wherever they may be, and same for the physician potentially.
Great, yeah, seems like an incredibly valuable tool at this point in time.
Yeah.
So this attendee is asking, what is a bedside ultrasound? And just wants to know what your thoughts are on wearable technology overall, and if you have any particular models that you would recommend.
Sure. It's a great question and actually a very exciting field. So bedside ultrasound, POCUS is another nickname for it, point of care ultrasound. We're really fortunate here at Abbott to have a very advanced program in ultrasound. So ultrasound, as people know, is just a way to image the body. So it can look at babies when people are pregnant, it can look at the heart and actually get very diagnostic images of how the heart pump's working, look at valve function. Those are a couple of special areas that the ultrasounds are really good at. So there's a term called an echocardiogram or an echo that we do a lot in patients. It's jokingly called a cardiologist vital sign because we essentially order it in almost everybody. But to be able to do those images, if I'm remote to the patient, so let's say the patient's in New Ulm, and we have a nurse there who's actually been trained in doing bedside ultrasound, so that nurse can put a probe on that patient's chest and actually take a handful, maybe just be a half dozen set of pictures of that patient's heart in motion. I can tell immediately how the heart pump is working. I can tell with a quick screen if the valves look generally okay or if we need to look further into it. And so that's way better than any stethoscope. If I'm sitting right next to you with my stethoscope listening to you, seeing those ultrasound pictures is going to be better every single time. And so the question is, how can we do it just as well as try and do it even better? And so if we can do bedside ultrasound reliably, that's a great tool for the cardiologist to feel like they got a good exam, they really understand what the issue is, and they know what the next step should be. So that's that part. I think in terms of home devices right now, there's good monitors for blood pressure. There's a lot of good blood pressure cuffs out there that are very cheap, so that's a great thing that we've been able to do at home for a long time. There's emerging technology in rhythms and checking if people have atrial fibrillation or abnormal heart rhythms. There's certain devices you can get for your phone where you can actually put your thumbs on there and actually give you two rhythm straps, or again, I mentioned some patches that are being worked on by one of my partners that potentially will be able to allow people to be monitored for weeks on end with just a little patch that's the size of a Band-Aid. We're working with a group to really try to develop smart ultrasound probes. So perhaps in the future you'll see a kiosk when you go into your pharmacy or go into Target or wherever you may go, where you can truly have a probe that's smart enough to have the person actually take their own pictures, because it'll give you a scale from 0 to 100 to tell you what's the quality of your picture, and you try to get to 100, so it's a little bit of a competition for the person. I watched a janitor actually do this in a demo, and within 20 seconds was able to get diagnostic quality echocardiogram images from a smart probe, because the probe's actually telling him whether he's getting a good picture or not. And so that's the future, is if people can actually do those things from home or do those things from a kiosk, do a really high quality exam, then that's all we need as cardiologists to be able to make a good assessment of what the next steps are. So like I said, a lot more to come. I think in 5 years from now, we'll be in a very different place from that standpoint, which is exciting to think about.
Yeah, absolutely. Thank you very much. So this attendee writes, it's basically a follow-up question to the wearable devices, but do any of these devices have compatibility with your EMR, for example, Epic?
Yep. Yeah, they do. It's a great question. And that I think will emerge even more as well. So part of what you'll hear a few of my partners, Steve Bradley and others say is, getting data is great, but getting good data is even better. And so you want to get the right data. So you don't just want to download, we have over 100,000 heartbeats in a day. So if you wear a monitor for 7 days, you don't necessarily need 1 million heartbeats to look at. You want to understand, was there something that was funny that happened there? So I think it's all a matter of how we process the data and making sure that we get good quality data. But yes, absolutely, there are ways that some of these patches and some of these ultrasounds will already go straight into the medical record. One thing that's been really a nice thing from our standpoint is the medical records from different hospitals are communicating better than they ever have. And so, for instance, if somebody has a CAT scan in a rural hospital, maybe for a completely different reason unrelated to their heart, it's now to the point where I actually not only see that report, I can actually see the pictures. And so I think as we go, those type of things will just get better and better.
Excellent. Thank you very much.
Yeah.
Looks like we have just a few questions left. So again, if you'd like to ask a question or submit a comment to Dr. Newell, please access the Q&A pod located at the bottom of your Zoom screen. This attendee, Cindy, writes, what is the average wait time to get a telemedicine appointment?
Yeah, so that's a great question. So the wait time is usually within the week. As I mentioned, right now we're doing them clinic-based, and so we've got the 16 sites that we do these visits. I think in the future, especially from what we've learned during the pandemic here, is that we may get to a point where it truly will be sort of like reserving your spot at a restaurant. You go into your online and say, I want a reservation with Dr. Newell at 6 p.m. to have a 20-minute conversation about this issue that I've been having. I think we'll get to a point like that over time where we'll truly be able to have patients from home with good wearable devices and wearable technology being able to pick a time that's convenient for them to be seen by the cardiologist and actually do it that way. But for now, again, it's done through clinics, so it's done scheduled the same way many clinics schedule, but most of our visits are that same week.
Excellent. Yeah, that's very exciting.
Yeah.
So this attendee writes, how does telemedicine help serve MHI patients worried that they may have COVID-19?
Yeah, it's so for COVID, it's helpful just in terms of having any visit. So, but with the COVID specifically, avoiding exposure. So if the patient can actually be at home, review symptoms, we do symptom screening for anybody that comes to the hospital or comes to our clinics. But actually, if they have concerns that they may have this, having the conversation with the physician, even as cardiologists, obviously, we've become well versed in what COVID looks like and what it sounds like and what symptoms are typical for this. And so being able to see a physician to review those is a great idea. As you might imagine, with this whole new world we're living in, internal medicine, family practice, a lot of these physicians that commonly deal with infectious issues and infectious disease doctors as well are doing virtual visits as well. So there's a way for patients to be seen, to be screened. And this works really well. And an example I didn't give during the talk was, on call one night, I mentioned how we do our inpatient visits for people that may be at risk. I did a phone call conversation with a patient that was recently transferred with shortness of breath and a history of coronary disease. And so the presumption was he was having a coronary issue. Understanding that his cough and his shortness of breath may actually represent COVID, I decided to do the outside of the room visit with him and had the conversation. His two main symptoms were shortness of breath and cough. So we actually ended up doing a CAT scan that proved his heart arteries were fine, but his lungs were filled with COVID. And so there's a crossover in some of these symptoms. Being able to have those conversations, facilitate those visits without exposure is a great way to have some of these visits done. So.
Right, yeah. So follow-up question. So for high-risk patients like those with heart conditions, would you encourage them to continue to stay home even as the state guidelines are loosening?
Yeah, it's a great question, and it's a tough one to answer very specifically. I would say that coming into a hospital is a safe place to come to. So if people have symptoms, have concerning changes to how they're feeling, they should come in and be evaluated. When you're coming to a hospital or clinic, these are places that are well versed in how to screen patients, how to take care of exposure, so the people that are there will be well masked and decrease their exposure and so on. So it's a safe place to come to. One of my partners actually worked with a group across the country to look at heart attack rates since this COVID pandemic started, and they've dropped almost 40%, mostly I think because patients are worried to come into the hospital. The hospitals are safe, the hospitals are open for business, they're available. We're here if you need us. So don't be afraid to come in because you'll be well taken care of, and actually your exposure risk, I personally believe, is less coming to a hospital than it is going to the grocery store.
Yeah, thank you very much for that. Looks like we have just a few questions left. The next one, if you could just talk a little bit about how receptive your team or your colleagues were to telemedicine.
Honest answer or the politically correct answer? There are a couple that were very against it, and a lot of the resistance was more around that exam component of, I feel much more comfortable being able to examine the patient. This doesn't seem like it's going to be a good way to see patients. And so there are a handful of people that really felt that way strongly at the beginning, and then as they did some of these visits, realized that, oh, no, actually this is a great way to do this. And they're not necessarily the people I would have thought when I started the program. So Peter Ekman, who I know has spoken at one of these talks and is the head of our advanced heart failure team, truly probably sees the sickest patients that we see in all of cardiology and all of medicine. And he's the one that's telling me that, well, 90% of what I do is the conversation, which is, I already know what their heart looks like on ultrasound. They've had every test in the world. We know that they're sick. Then the question becomes, what's the conversation about? What are your options? Okay, we can do X, Y, or Z. Here's what this looks like. Here's what that looks like. Here's what this looks like. What sounds good to you? And so if you can do that for a patient, that's in Fargo, 4 hours away, and have a meaningful conversation, and that patient gets a lot out of that interaction, that's the goal. And so there may be a handful of patients where the exam really would have made a difference in the next step. That's what we're trying to get around with some of these bedside ultrasounds and things, so we feel like we're actually getting as good or better of an assessment of the patient. So it took a while, and that's what I've encouraged as I've talked across the country about this issue, or these type of programs, is there's so much resistance because most of it's unknown. But I think once the patients, as we saw from that survey, really actually like these visits. My partners that have done these have said, this is actually a great way to do that. And people like Peter Ekman and Dr. Abdelhadi, who runs our EP program, they do a lot of these visits and really find them very rewarding and very convenient for them and the patient. And again, very high procedural yield for my surgical partners.
Excellent, thank you very much. Looks like we have time for just one more question.
Yeah.
I think it's a good one to end off on. So what are you most hopeful for / excited about with the future of telemedicine?
Yeah, it's a great question. I think it's, the convenience factor. We live in a convenience world, right? So you can shop for everything at home in your pajamas, and can you see your cardiologist as you're traveling or as you're at home? I think that's very exciting if we get to the point where the wearable technology is reliable and very good, and we have a good way to look at that data. We absolutely can do a lot of these visits when people are traveling. So if you're worried about traveling to some remote location, you can take your cardiologist with you. That should be very reassuring. And so I think that's the exciting part. I also think it's very exciting that we're truly at an infancy of telehealth and cardiology. I think cardiology is such a busy subspecialty. People are so busy, there's so much to do, there's so many patients that need cardiology, that this was seen as a novelty that's maybe not necessary. We look for silver linings in things like these pandemics, and one of the silver linings is I think people have realized, wait, there's a lot of good uses of a program like this, and there's a lot of ways that can actually help us be more efficient and take better care of patients, which of course is what we're trying to do. And so I think there's a lot to be excited about. I think it's been a rewarding experience for me and for our team, and it'll continue to be so.
Excellent. Well, thank you very much. Before we hand it back off to Chris, is there anything else that you'd like to say to our audience here today?
No, thanks for having me. It's great to be a part of this.
Absolutely. Thank you for presenting, and thanks for taking questions.
Yeah, thank you.
All right, great. Thank you, Dr. Newell. And thanks everyone for your great questions. We all learn a lot from the questions you submit. And we do want to say a sincere thank you for making the time to join us. A key part of our mission is cardiovascular education, so thank you for being a part of that. Here you can see on the screen many ways to stay connected with us. We're working hard during these times on Facebook, Twitter, LinkedIn, Instagram. So please check out those sites to learn more about what's happening at the Minneapolis Heart Institute Foundation. And if you're interested in supporting our work, we welcome that, and you can click on this website that we have right on the screen. I hope you will join us again, that you enjoyed this On the Pulse presentation. And on June 2nd, we have Dr. Bobby Steffen presenting on the history of cardiac surgery. And he is a MHIF researcher and a very respected cardiac surgeon. I think you would enjoy hearing from him. Again, that's June 2nd. Please register. And thanks again for spending the time with us today.